You're tuned in to RX Radio.
Ladies and gentlemen, welcome back to RX Radio. Today, you've got me, Dr. Jordan Jiunta, and I've got you. So thanks for tuning in today. Before we get started, I just want to kind of give you guys an update about where we're at with Prescript. Right now, we just launched level 1 for our final intake of the year. We'll have another intake this year, but the class won't start until January. So October 22nd, 23rd, whatever that Monday is, will be the last level 1 of the year. That is up for sale right now. We currently also have a level 2 up for sale. That I believe will be the last of the year as well. And this past week, or 2 weeks ago, I guess by the time this comes out, we put level 3 up for sale. We started with 3 weeks of the level 3, and they literally sold out within minutes, all 3 weeks. So me, Jordan, and Matt were all in the group text like, should we put another week up? Like, yeah, fuck it, let's do it. Put a 4th week up, it sold out in minutes. Put a 5th week up, it sold out in minutes. Put a 6th week up, and that sold out in about hours, we'll say. So this year we will be running 6 weeks, January into February, of the Prescript level 3 down in Tampa, Florida, at Yo Murphy's facility down there, Yo Murphy Performance, with the next class of the 2026 Combine athletes. So that'll be fucking sick. I'm so stoked to see you guys out there. I appreciate you guys for the response with that. That's huge. And that'll be cool. It's a really good time. It's been really cool the last couple years working with these guys, seeing them through the process, seeing them ball out at the combine, seeing them get contracts, and then seeing them play on the field during the season. It's pretty fucking cool. So if you guys are coming out to level 3 this year, I'm so stoked to hang. I'm so stoked to meet you guys, and you're going to have an unreal experience. Yeah, so thank you guys for that. Pumped for what's coming in the future, especially for our new intakes. This crazy, it's fucking crazy. This year we will actually have put more level 1 students through the program than any other year. So a lot of growth. So we'll see what level 3 looks like in 2027. We might be able to run the whole camp, the whole 12 weeks of it. So I appreciate you guys for that. Now, with my Diet Coke and free promo, Decky, I don't know who they are, but Garrett does, with the Zins. That speaks to my mental state right now. However many things that I need to make me feel like I'm in a place to talk to you guys for 45 minutes to an hour, that's my mental state. So Diet Coke and Zins today. But on a more serious note, what I do want to talk about today is low back pain. I think anyone who's ever trained, played a sport, worked with clients as a trainer, you have either experienced yourself low back pain or you've had clients that have dealt with low back pain. And it can be pretty crippling at times. It can be scary. A lot of people don't understand or know what they should and shouldn't be doing when they have low back pain. And a lot of times people with bad advice kind of take this as a life sentence. They think that there's something wrong with them indefinitely. So I want to talk about kind of 3 different reasons that people have low back pain. And these are probably the 3 most common that I've seen in my practice and that I've helped people with over my career. So we'll kind of dive in. We'll talk about each of these in a similar way. The first one is going to be probably the most common, something that everyone deals with to some degree at some point, and that's going to be muscle strain or ligament sprain in the low back. So that means that essentially there's damage to either the muscles or the ligaments in the low back, and that could be spinal erectors, it could be QL, it could be anything really that's going to create tension in the low back that sends a sensory input up to your brain that you are going to register as pain. Along with the ligaments, we have our SI joint ligaments, we have lumbar ligaments, we have ligaments between our vertebra, we have ligaments between our vertebra and our sacrum and our ilium. So there's a lot of structural ligaments within the spine. And when we're looking at damage to these things, it's typically due to, and we'll talk about this a little bit differently later on, but it's typically due to overloading those areas in somewhat of an acute way. So a lot of times this doesn't have to be in the gym, but if someone's getting low back pain in the gym, it's going to be either a sprain, or it's going to be a disc herniation, which will be the second one that we talk about. So a few ways to kind of differentiate the two of those, but also kind of what you're looking at in terms of tissue damage, healing time, and kind of protocol to recover from something like this. So when we have a sprain or a strain, a lot of times the symptoms that you're going to have is going to be muscle guarding, all right, or reactive muscle spasm, where essentially your nervous system, your muscles, everything is kind of acting to protect that area in which there was tissue damage. Now, these are things where there's specific structures are being overloaded. It could be somewhat of a chronic way, like if you have really shitty deadlift technique and you deadlift really shitty every single time, it might just be one of those times that, you know, it's the needle that or it's the straw that broke the camel's back. It could be the thing that is, you know, it's about to go and you did nothing different. You seemingly moved the same way you always move. You did the same warm up. You slept. You ate everything the same. But it's just kind of this one instance where something goes. And that's not to say that your technique's shitty, but the thing about injuries like this is that it typically is how you're moving or what you're doing that has caused this injury. Whether it's an accumulation over a period of time, like I just described, or whether it's a certain instance where maybe you have great technique, you move really well, but you're just a bit under recovered on one day, or you overreach a little bit too much, you lose positioning, and that's just too much force for the tissues that we're loading, and we strain the muscle, we sprain a ligament. That's typically what I see with things like this. And there's always, of course, like the very acute cases of like on the field athlete, like someone takes a hit or someone just moves in a way that's a little bit unpredictable and there is tissue damage. So typically what people see with this is that it gets very stiff right away. And especially when we're talking about the back and close to the spine, your body really wants to protect those areas. So if there's a chance that there's a threat to your spinal cord, your body's going to do everything it can to kind of dissuade you from moving in a way that would expose you to that risk. So that's why muscle spasm around the spine feels really fucking bad. And it can be really debilitating. And it's something that you don't really want to push through. So that's typically what you're going to see with an injury like this is that reactive muscle spasm. Now, I mentioned that we'll talk about disc herniation after this, but a big distinction between a muscle strain, a ligament sprain, and a disc herniation is that typically with a muscle or ligament issue, you're going to have very localized pain. All right, pain that is local to the area that is injured. There may be some swelling, bruising, redness, inflammation there, but it's atypical for there to be nerve root involvement with that, meaning that you're getting pain that refers down the leg into the foot even. And that is something that is more characteristic of a disc injury. So that is one thing you can use to kind of differentiate the two is this pain more local, or does it kind of shoot? Does it move? Does it go down the leg? If it's more local, you're probably dealing with more muscle ligament. If it's moving on you, there's probably some sort of nerve involvement. But we'll get to that in a minute. Now, if this sounds like a situation that has happened to you, and maybe I should put a disclaimer in here. This is not medical advice, and I'm not helping you diagnose or treat any issues. I am just spewing information in the internet, which I don't know. Most people that give you information on the internet, they don't tell you that, and they're full of shit. So I'm going to tell you that. So I have no liability, so I can say whatever the fuck I want now. I'm going to keep it helpful, but still. So when we're looking at someone with a muscular strain or sprain, the thing that we need to understand as we start to look towards intervention is that there is tissue damage, right? And we need to be very careful with the way that we load this area in a period where that tissue is damaged. Because if we introduce too much load, too much range of motion too soon, we could create more tissue damage. Or in the best case, we can prolong the healing process, right? So that's a big distinction here around muscle strain, ligament sprain, is that we don't want to load these tissues too soon. I know a lot of, voices in the echo chamber of the internet kind of talk shit on rest. And I'm probably one of them in certain contexts, but let's define rest in a specific case of injury. Rest in this specific case means that you're resting the damaged tissue, right? We're not loading those for a period of time, because collagen remodeling, tissue healing is probably going to take, on the low end, 6 weeks, on the higher end, maybe 12, 14 weeks for that tissue to be healed. Now, when I say that tissue is healed, now it's healed to a relative structural integrity that will allow us to load it again, but it's not healed to the point of pre-injury, right? So we can't just pick up where we left off or ramp up over that time that at week 12, all right, it's fucking go time. No, it means that there's going to be, we'll say 6 to 12 weeks of time where this tissue is still damaged to some degree. So when I say rest in this context, I don't mean like go take 6 to 12 weeks off of the gym and like go on a vacation or like, go do whatever. I mean that we're resting the specific tissues that are damaged. Like anything you can do without increasing symptoms in the area, fucking do it. And like test these things before you go and you do them 100%. But if you can do them and it doesn't affect the symptoms in the area, there's not going to be an issue in most cases. There are like, we need to think of like overall fatigue and like neural load and things like that. And we still want to make sure that you're allowing yourself kind of all the substrates you need for tissue recovery. Yeah, absolutely. But in terms of tissue damage, if it's not increasing your symptoms, it's probably not going to make it worse. So resting, in this case, we want to rest any damaged tissues, but still do the things that you can do to the capacity you can do them without making the injury worse. But there's no way around that. You need to let the tissues rest for a period of time where there's at least enough healing that has been done that you can start to load these tissues without the risk of re-injury. And then from there, as we start to load these areas, that reactive muscle spasm can cause compensations that far outlast the tissue damage. And that's what you kind of see with people that have had kind of these long-lasting low back injuries. Like I threw out my back in high school and 20 years later, I'm still not the same. A lot of times, the reason for those cases, like barring any structural issues or whatever, is that in these times where the tissue is healing and people have that reactive muscle spasm, it's going to change the way that you move. There are going to be compensations that allow you to get out of bed, put one foot in front of the other as you walk down the street, drive to work, do whatever you do throughout the day, that are going to allow you to do those things. But you're going to be doing those in a skewed way, and you're going to create asymmetries because your body's very literally protecting a specific area. So the first phase of rehab, and this can start almost immediately, is it's always understanding the compensations that are going to occur from this injury and then doing something to mitigate those. And that's not loading, that's not a contralaterally loaded Bulgarian split. It's not anything like that. Like I'm talking just using the parasympathetic nervous system and breathing drills and gentle like range of motion challenging things like that to start to reduce muscle tension and to start to understand that, like, all right, if 75% of the weight is on my right leg throughout the day because my low back hurts, like I need to get some exposure to putting weight back on my left leg. And the art or the skill to all of this is understanding how much stimulus is appropriate at the right time. And that is what differentiates your common chat GPT to high level trainers and rehab specialists, right? People that can do that, and they can do that well. And that's, I don't have any, witty advice on knowing how to do this, aside from, if it's yourself, listen to your body. If it's your client, listen to them. Subjective sensations are going to be the number one thing that guides this process from the start, from an early stage, is that we want to listen to things that are causing pain. We want to be able to differentiate, is this a pain that resembles the same symptoms of the injury? Is this a discomfort of starting to lengthen tissues that have been contracted, guarding this area? And understanding kind of the different subjective components of what someone is feeling as we challenge their range of motion and their capacity through these tissues, that's going to be the scalable part of this. So really understanding what people are feeling, and then interpreting exactly what that means, right? Are we exposing them to risk for tissue damage again? Or is this something that, okay, we actually need to challenge you in this way to continue to have progress? So kind of to sum that up in less words, we need to first understand that there are going to be compensations that come from this injury, while also understanding there is tissue damage present. And then from there, we need to start to mitigate those compensations while starting to reduce the muscle guarding around the area. And then the part that, again, there's a tack to this, is you have to be able to progress the stimulus at the appropriate rate, understanding that tissue healing time, understanding the subjective sensations that someone is feeling in that area. And then even past that, also kind of trusting in the fact that they're going to be able to progress this thing at a reasonable rate, and understanding that if they're not, like, yes, in an ideal world, we could just add 5 pounds or 2 reps every week or whatever that looks like. But reacting to those real world times where they're not ready to progress, I think that's the most important part. And if we look at prognosis for something like this is something that, if you do this process correctly, it should not be a long-term issue, right? And I guess kind of a caveat to that is that, depending on the degree of an issue or of an injury and how much tissue damage there is, it may be something that goes away completely if it's managed well, or it may be something that needs long-term maintenance, right? That just meaning that in long-term maintenance, in my mind, is like, I can do X, Y, and Z when this flares up, and it gets it to flare down, or it gets the flare up to go away. And then that allows me to do the things that I want to do. That's management. So more serious injuries, it's not going to be that it just goes away. It's going to be that it's managed long-term, and that is success, right? And that's an important conversation to have with people that have these injuries as well, because if you can manage expectations appropriately, like if someone, I don't know, tears their spinal erectors off the bone, I don't know how the fuck you would do that. I'm sure someone's done it though. It's not going to be the same 10 years down the line, 20 years down the line. There's going to have to be some ongoing management to allow them to function at their highest potential. But that is success in a case like that. If we just give up and we just say, okay, you're going to have back pain forever, here's these oxys, like that's not success. Like that's just neglecting the issue. So also just managing expectations, but that's a conversation that if you say with your clients, like, look, I don't know where this is going to end up, but I know that we can make this better. And I know that if we pay attention to the things that make it better and the things that make it worse, then this is something that we can manage long-term. And that's exactly what we're going to do. So, I mean, I guess with that, there's a lot of concepts that are going to carry over to the next injuries, but I'm going to move on to kind of talking a little bit more about disc herniations now. So mechanism of injury can be pretty similar with disc herniations as like sprain injuries as well. They can also happen acutely. They can happen, seeming like from just a single incident or injury. And they can also happen from just repetitive stress, like literally the way you sit at work every single day. Now, the difference between a disc injury and a muscle or ligamentous injury is that, yes, muscle, ligament, like they're more structural components. Ligaments definitely, muscles going to be very functional. The disc itself it kind of blurs that line between structure and function, right? It allows us to be mobile through the spine. It is very important for the structural integrity of the spine. It is kind of like a shock absorber for axial loading, for being upright weight bearing. But a disc herniation itself, we have kind of this liquid-like substance in the middle of our disc. It's called the nucleus pulposus. And then out around that, we have kind of this, they call it a basket weave. So these overlapping fibers that kind of cross over and create this really structurally strong kind of fibrous encapsulation of that nucleus pulposus. And what happens in a disc injury is those fibers, they start to tear. So we get tears in that, and then the nucleus pulposus starts to push out, push out, push out. And what that does, it can create a bulge on those outer fibers. And this in itself will not cause symptoms, but when this does cause symptoms, it's kind of one of two things. It's because there's inflammation around that bulge because of the damage to the annulus fibrosis, and so inflammation can cause discomfort, and it could cause nerve root issues. Or the second one, when this really becomes an issue, is when that disc bulge is actually putting pressure on the nerve root, because it typically, the way that these bulge, because we have a ligament down the front and a ligament down the back of our spine, they bulge right into the area where the nerve roots exit the spine and they go out peripherally. So typically when you have someone that has an issue, a disc issue that's causing symptoms, it's because either the inflammation is interfering with the nerve root, or there's actually something physically, like that disc bulge, putting pressure on the nerve. Now, there's different degrees of these injuries, obviously, but we're going to stick with more kind of like the mechanical disc bulge, like a disc is bulging, putting pressure onto a nerve root. Now, this is a soft tissue injury. So just like we said before, with the muscles, with the ligaments, as we look at a soft tissue injury like this, these do heal, and discs are vascularized, and they heal relatively well. I think that there's kind of this misconception that once you herniate a disc, it's always herniated. And if it's more of a chronic case and it calcifies and there's kind of more permanent changes, then yeah, it kind of is what it is structurally. But in someone that's young, someone that's healthy, someone that's active, you're probably going to have disc herniations. You probably honestly have them right now. And a lot of times they're asymptomatic, right? We can have these issues and they don't put pressure on a nerve. We never know that we had it, and it just kind of heals and it goes away on its own. The issue is when it does cause pain, because the type of pain that this will cause, it can be pretty debilitating. These are ones that are more nerve type or electrical sensations. Some of the symptoms, if it's up to a higher degree, are that you'll have muscle weakness in the nerve distribution of that nerve that is being impinged. And if it is worse, because of that muscle weakness, over time you can actually get muscular atrophy in the muscles that nerve distributes to. So these can be a bit more of a severe injury, because it's not just the area that's injured, it's actually affecting the whole nerve distribution, and not to mention like pain through that nerve distribution as well. So these are ones that people usually take a little bit more seriously, and they can have longer lasting consequences if they're not managed well. But it's the same process with these, managing these, as it is that we just walked through before for a strain, for a sprain. It just looks a little bit different, because the tissue damage is not necessarily the area in which we're having symptoms a lot of times, because you will get similar symptoms of the muscle guarding. Muscles will tighten up a lot in the low back. You get a lot of psoas tightness as well. The psoas attaches to the lumbar vertebra, so the nervous system will kind of use that to prevent movement through the lumbar spine. And a lot of the compensations are they're kind of more encompassing than a lot of times the locality of a muscle strain or sprain. So in my mind, that gives us greater opportunity to make someone comfortable without having to really do any axial loading or anything in the area of that injury itself. So like things that are going to be helpful in that kind of baseline process of, all right, what compensations are going to develop from this? We need to look at how they're moving through the hips, and that's going to be like psoas, like what's the tone of the psoas? Can they get through hip flexion and extension? A lot of times with disc injuries like this, you'll see either people have a flexion or extension bias, meaning that one of those directions, either flexing the lumbar spine or extending the lumbar spine, relieves symptoms. So that can be a really helpful piece of information, is that, all right, if you feel better in flexion, guess what? We're going to do all of our corrective exercises in lumbar flexion, or we're at least going to avoid lumbar extension. And that's going to be one of the last things that we'll test before we start to add in any sort of demand through lumbar extension. And then along with that, there's a lot of potential through releasing muscle tension through the lower body, through like rotation of the hips, like I said, flexion, extension of the hips as well, to start to diminish the symptoms that someone's having. And a big thing, I didn't mention this with the first one we talked about, lumbar sprain or strain, but this holds true for both of those and for disc herniations. The biggest thing that you can do to help someone not have these injuries again is to help them build awareness around why this happened in the first place, right? The majority of both of these injuries that I see are from people that are probably not necessarily beginner athletes, but maybe like beginner to intermediate. They're kind of in that realm where they don't have a ton of awareness around how they're moving. They don't have the best technique, but they enjoy training. Maybe they've gotten into strength training and they're starting to build up a baseline of strength, but the way that they're loading isn't consistent with body mechanics. And a lot of times that comes down to them not understanding how to properly use their core to transfer force from the lower body to the upper, or the upper to the lower. So either of these injuries, that's going to be like buy-in baseline, is starting to build awareness around how to control the core, how to resist movement through all three planes, and then starting to continue to progress that stimulus and make it more dynamic over time as symptoms have reduced, as tissues have healed. So that's kind of the realm in which I'll start with managing people with disc herniation. Is first off, you need to find the range of motion that they're okay to move in. You need to find the ones that they're not okay to move in. You need to find the range of motion that they're restricted in from the injury. And then you just keep them in ranges of motion that don't increase symptoms. And you find exercises that they can do in those ranges of motion that will start to reduce the tension in the areas that they're restricted. Because that muscle guarding that's going to be their body saying, we're not going to move this way because we don't want to put any torque through the lumbar spine. Now, if we're increasing their ability to move freely and increasing their potential to create torque through the lumbar spine, the thing that we have to teach them, and this is very much teaching, is you need to teach them how to consciously and actively protect that lumbar spine through core bracing. One of the ones I found pretty successful even with people that are in a pretty acute state with this is if you have someone lie on their back and you can do like just knees bent. It's essentially like a McGill's curl up, right? Knees bent, feet on the floor. You're going to have them do a curl up and kind of contract the abs. From there, you can progress that. You could go 90-90 with the legs. You can put their feet on the bench. And then from there, we're just going to continue to progress that stimulus, making that more and more demanding, getting them to understand how to create space through the back of the lumbar spine. That's where the nerves exit, right? So if we can flatten that lumbar spine, a lot of times that's going to give them relief from the symptoms. And just like we said with strain, sprain, probably 6 to 12 weeks of tissue healing time, because remember, herniated discs do heal, and they will heal if you let them, right? If you start loading too soon, you go back to normal activity without any sort of focused intervention, then yeah, you're probably gonna do the same shit again, and you might end up with a bad back. But if it's something where we're ramping up the intensity of what they're doing, as there is some sort of learning around how to control the lumbar spine, stabilize the lumbar spine, restriction in movement in the hips is always going to create more tension on the lumbar spine, right? So making sure that they're not restricted through the hips, increasing their stability in unilateral stance, their ability to create rotation through the hips, open and closed chain. All of these things are going to be strategies that take stress off of that lumbar spine. And as they learn how to do this more consciously, then that's going to allow them to move more freely with less stress on the lumbar spine. And as long as they're bracing their core, you can more evenly distribute that stress through the musculature. And that's going to be kind of the long-term key for managing disc herniations. Now, we'll kind of get into management, as I just very much hinted towards. When it comes to management of disc herniations like that, the longer that these things are going on, the more persistent the symptoms are going to be. I'm a fucking idiot, and I competed in Olympic weightlifting for a long time, no matter how bad my spine hurt. And because of that, I have some very real, ongoing neurological weakness through kind of the posterior side of my right leg. And that's something that it doesn't bother me. And I can train very high intensity, and I can train very high capacity. But if I'm not doing specific things, then I'm going to get numbness, I'm going to get tingling, I'm going to get specific muscle weakness, I'm going to start to rotate in my squats. There's going to be kind of a cascade of things that happen that tell me hey, you're not doing what you need to do to maintain this injury. So things are going to start to break down. And for me, that happens to be a lot of glute and hamstring isometrics on that side. A bit more of a focused warm-up. I do a lot of unilateral accessory work, like B-stance RDLs, and I'm talking loaded B-stance RDLs, and walking lunges. And a lot of these things, they start to just look like normal exercise over time, and they should be part of your normal regimen. But as long as you're doing these things consistently, it's going to maintain a level of symmetry and a level of function where you're not having issues from these injuries that, even if they were long-standing, or even if there are compensations around them, you're able to maintain and you're able to still train at a very high capacity. And that's success in these cases, right? And again, that's something that we have to be aware of, and we have to build that understanding with our clients. But these could be things that go away completely with proper management short-term, or they could be things that require ongoing management as long as that person wants to train and walk on both legs. But either way, there is a metric for success in that, and that's being better than had you not done these things, right? Being better than had I not maintained and understood that I need to do a good warm-up and I need to have specific accessory work in my program on an ongoing basis so that I can continue to do things that I want to do. Sometimes I just need a second. I just need a second here for some Diet Coke, and I'll throw another Zen in. But we're going to talk about one more. And this is one I hear about all the fucking time. The reason this is common is because every single person, if you're lucky enough to live long enough, you'll encounter this. And it's not necessarily an injury. It's not necessarily a diagnosis. It's not a disability. Maybe it is in some cases if it progresses. But it's degenerative disc disease or spinal degeneration. Anyone probably over the age of 40 has gotten an MRI of your spine. You've probably had this on the report. And it sounds scary. No one knows what the fuck it means. But essentially what degenerative disc disease is, or spinal degeneration, it's... So over time, just being weight bearing and living in a solar system with gravity, our body starts to respond to the way that we're weight bearing, and it starts to stabilize in a way where it allows us to continue to do the things that we're doing. So the way that our body stabilizes bones and joints is with calcium deposits. So basically what it does over time, in areas that are higher stress, lumbar spine, cervical spine, like depending on your day-to-day positions, stressors, how you train, how much you don't train, all of these factors, the day-to-day just like activities that you go through, your body's going to stabilize according to the stressors that it encounters. And over time, over your lifetime, it's going to start to lay down calcium on your spine to stabilize your spine. That's why old people, 70s, 80s, if you look at them, they all have kind of the same posture. It's because their spine just stops moving eventually because there's so much calcium that they don't have those nice flexible discs that they used to have. Now, it can cause issues. Don't get me wrong. I'm not completely downplaying it, and it can be a real source of symptoms and lack of function for a lot of people. But I think most people that are young enough and active enough and they have it on an MRI, it's probably not an issue. When it becomes an issue is when you have this at an accelerated rate in specific areas. And of course, if there are symptoms related to it. But what can happen, especially in the spine, is that in areas of high stress, we get these calcium deposits. It's very much like the disc injury that I just talked about, is that these calcium deposits can start to put pressure on the nerve roots. Or what they can also do is they can restrict movement in specific segments, which forces other segments to be overstressed, or it forces them to move more than they should be within a normal range. And that starts to become an issue. We can absolutely have neurological symptoms with this. We can have a lack of function in terms of range of motion. There can be pain, achiness with things like this. It's absolutely possible, and I'd say it's even probable in a lot of cases. And the thing about disc degeneration or spinal degeneration is it is a progressive disorder. It will continue to happen, and it will progress over the course of your life. So once we start to see it, then that's kind of a warning sign that, okay, there should be some sort of intervention around this, right? And it can give us hints if it's in a specific area. If you're, 25 and it's in your cervical spine, you probably should get off your fucking cell phone and, stand upright every now and then. But if you're 55 and it's, throughout your entire spine and it's a minor degree, it kind of is what it is. Like, that was going to happen one way or another. But the thing that is most helpful to know with disc degeneration or spinal degeneration is that the best thing for it is movement, right? Where we start to get more degeneration is if we stress the spine more. So it should be obvious, but it's not always. But things that are going to protect the spine are things like I just said, understanding how to brace your core properly, And if we're talking, I know we started low back, but if we're talking like full spine here, any restricted movement at the shoulder, the scapula, or the hip joint, they're all going to stress the spine more so. Because if we're not moving properly in one area, then the adjacent areas to that are going to have to pick up slack. There's going to be at least more stress to get more movement out of that. And that can cause inflammation, and it is kind of chronic inflammation that signals our body to lay down calcium in these areas. So the strategies to mitigate the progression and the symptoms of degenerative disc disease or spinal degeneration. I keep saying both of those because it's called both of those. Being able to move properly through your hips, through your shoulders, being able to brace your core in isolation and kind of dynamically. But more than anything, it's movement, is creating enough movement. Like, we should be able to flex and extend our lumbar spine. We should be able to rotate our thoracic spine. And if we can't do those things properly, then we start to stress one area or the other because it has to pick up the slack from the other one. So the treatment for all of these things, it really comes down to, first and foremost, awareness. Is we need to have awareness of what the injury is. Is it specific tissue damage? And what is that specific tissue? Is it muscle? Is it ligament? Is it disc? Is it more so, wear and tear? That's what I'd put spinal degeneration into that category. It's more so wear and tear, right? Like, you have 200,000 miles on your Toyota Corolla, like, you're going to have to replace some belts and your radiator and whatever the fuck you replace when your car has that many miles, right? So there's wear and tear on the spine just because of the things that we do, and we want to be able to do those things long term. So we need to know how to reduce the stress on those structural components and keep them more so in the functional components, right? Which are our muscles. We need to train our muscles. We don't need to train our spine. So the treatment it's just responsible movement and responsible programming, right? We need to have things ongoing in someone's program that's going to allow them to rotate through the thoracic spine. It's going to allow them to stabilize flexion, extension, resist rotation in the lumbar spine. And we're going to have things in their program that are going to encourage them to rotate through the hips and not rotate through the lumbar spine, the SI joint. And that's kind of, in a nutshell, everything you need to know to prevent low back pain. That's not 100% true. And there are things, outside of this, more like traumatic things, like spinal fractures, SI joint issues. There's different things that kind of layer into this and influence decisions that you'll make about it. But if I were to boil it down to a few key points to what you need to know to manage and reduce low back pain for yourself, for your clients, number one is going to be awareness. We need to know exactly what's going on to the highest degree of specificity that we can. And then once we have that awareness, then we also need to be able to almost assume the compensations that are going to come from that. And sometimes you don't have to assume. Sometimes you can literally just observe them. If it's more acute, that's going to be something that there's going to have to be a little bit of assumption in. But if it's something that's longer standing, they should present themselves. And then what we do is we educate people on how to use their core. The core is going to be the musculature that reduces stress on the spine. So, understanding pelvic tilt, understanding how much rotation should be coming from the hip and how little should be coming from the spine, the lumbar spine particularly. And then once you have that understanding of all these things, it just becomes programming. You find exercises that check these boxes, and then you progress them to the degree that person can progress them. And as long as you're doing that on a continuous and ongoing basis, that's going to be your best tool to mitigate and manage low back pain. I'm going to take a drink. So like I said, this is something that all of us have dealt with, whether it's ourselves or our clients, or if you haven't, I'm sorry, you probably will at some point. But it doesn't have to be a major thing. And it's, I've had people with spinal fusions. I've had people with all types of spinal surgeries, like cysts, weird things on their spine, that we can still get them to train. We can get them to manage symptoms in a very reasonable, intelligent way so that they can function at the level that they need to. So this doesn't have to become something that is ongoing or it's the first thing on their mind. So I hope this was helpful for you guys. I should have Shallow back on the podcast here pretty soon. Life is crazy, but we should be syncing up our schedules in the near future. If you want us to go back and forth and riff on something like this, or if you guys have other suggestions, just hit us up. But if you're still here, I appreciate you. Thanks for listening to me just kind of yell into your ears for the last 45 minutes, however long this was at this point. But if you guys have any questions, don't hesitate to reach out. I appreciate you. Thanks for listening.